Hello, I'm Dr. Richa Purohit. I'm the founder of Fitwell Physiotherapy, Kharadi, Pune. I have 10 plus years of experience in neurological physiotherapy. I'm presenting a case on effect of facilitation techniques with progressive kegels in post-stroke patients with pelvic floor dysfunctions. A stroke occurs when blood flow to the brain is interrupted and causes cell damage. The extent of a stroke depends on the location of cell damage and type of stroke. The main classifications of stroke are ischemic, hemorrhagic and transient ischemic attack. Ischemic, blockage of an artery located in the brain. Hemorrhagic stroke is a rupture of a blood vessel located in the brain. Transient ischemic attack or TIA is a smaller, brief blockage of an artery to the brain, also known as a mini stroke. TIA may also be a predictor of a more serious stroke in the future. Pelvic floor dysfunction refers to issues related with pelvic floor muscles. This could be due to muscle weakness or tightness. The patient was a 40-year-old Indian male with sudden onset of heaviness of both lower limbs, involuntary movements of fingers of both hands, and slurred speech. This was followed by multiple episodes of vomiting leading to unresponsiveness and a history of headache and sweating prior to this episode. CT brain suggested pontine hemorrhage with accelerated hypertension. The patient was intubated and shifted to the ICU immediately for further medical management. He was discharged on the 12th day and was conscious, irritable, blurred vision and intermittently obeying commands, weakness in all 4 limbs. On physical examination, the patient was found to have blurred vision, weakness in all 4 limbs, left more than right, involuntary movements on left side extremities, unable to communicate and swallow, and was disoriented. Sitting balance was poor, requiring 2-person assistance for walking. On examination, the patient was having slurred speech, hearing and visual disturbance noted. Difficulty following commands due to impaired hearing. Continuous shaking observed in left upper and lower limbs. Left side paresis with diminished proprioception. Spasticity rated 2 on an Ash scale on the left side. Poor trunk stability, unable to sit without support. No ability to walk. Weak muscle strength, contributing to poor posture. Experiencing shoulder and pelvic pain. Impaired bladder and bowel functions as well as erectile dysfunction. Condition explained to relatives and therapy was initiated. He was treated with proprioceptive neuromuscular facilitation (PNF) intervention. A rhythmic initiation technique was given for the left upper and lower limb and with improvements in voluntary motor control. It was done with a combination of isotonic and dynamic reversal. Pelvic bridging was done with a combination of isotonic techniques. Pelvic diagonal patterns emphasizing anterior elevation and posterior depression were practiced. Exercises gradually progressed to chopping and lifting patterns in sitting. Rhythmic stabilization and stabilizing reversal for the upper trunk in a half standing position with the affected lower limb in weight bearing. The bilateral reciprocal asymmetrical pattern for the arm in standing was started once the strength in the upper limb and lower limb improved to promote bearing in the affected lower extremity. All these activities were done for 10 repetitions with rest time as needed by the patient. Gait training with approximation given through the hips in the stance phase to promote weight bearing in the affected lower limb for 15 minutes was done. Progressive kegels added for posture muscles, trunk strength and stability, and pelvic floor dysfunctions. Pelvic floor anatomy and the importance of breathing have been explained. Muscle strength was recognized on a scale and exercises progressed gradually. Earlier, the patient was not feeling pelvic floor muscle contraction at all. By third week, he was confidently following the movements and started gaining confidence. He attended rehabilitation for 50 sessions, 6 days a week, lasting about 1.5 hours per day. The results of this study demonstrated that the PNF interventions along with progressive kegels have a significant effect on balance and gait. The findings show that spine and posture stabilization have a significant effect on functional mobility in stroke patients. Improvement in lower limb motor recovery was more accelerated. This is attributed to the pelvic PNF patterns and pelvic floor rehabilitation. Bird balance scores improved from 4 to 48. This might be attributed to the trunk and abdominal muscle activation achieved with stabilizing reversal and rhythmic stabilization in half standing position. Stance phase weight bearing of the affected leg improved with hip abductor activation, preventing pelvic asymmetry and compensatory lateral tilt of trunk. Ankle dorsiflexion, though not attained full range, the partial range facilitated ground clearance and improved plantar flexion momentum facilitated gait speed. Pelvic pain remarkably reduced and erectile dysfunction started getting better with progressive kegels. In this present study, the balance ability and independence in the gait of patients improved with the application of PNF. Pelvic floor disorders and posture correction owe to the progressive kegels. Research indicates that PNF stretching, both the CR and CRAC methods, is effective in improving and maintaining ROM, increasing muscular strength and power, and increasing athletic performance, especially after exercise. However, proper protocol merged with progressive kegels and consistency must be followed to attain and maintain the benefits of PNF techniques. Further research should be completed to prove the efficacy of each of these mechanisms in the factors affected by PNF and pelvic floor rehabilitation.